See, the heart is a muscular pump. So when the heart pumps, the blood has to go in a forward direction from the heart into the body or from the heart into the lungs. So whenever the heart tries to relax, the blood tends to come back into the chambers from where it has already come out. So to prevent this backflow in the reverse direction, there are 4 valves in the heart. On the left side of the heart, we have the mitral valve and the aortic valve. The mitral valve is between the left atrium and the left ventricle. So when the blood goes from left atrium into the left ventricle, the mitral valve prevents it from coming back from left ventricle into the left atrium. Similarly, when the left ventricle pumps, the blood goes into the artery called as the aorta. The blood cannot come back from the aorta into the left ventricle because of what is called as the aortic valve. So valves are one-way valves. These are there inside the heart. There are 4 valves and they regulate the direction of the flow of the heart. The aortic valve is situated between the left ventricle and the aorta. The aorta is the largest artery of the heart. When the left ventricle pumps, the blood goes through the aortic valve into the aorta and the blood is supplied to the rest of the body. Now, aortic valve can get diseased sometimes. There are 2 kinds of disease we generally see in aortic valve. One of them is the valve can leak, the blood can come back into the left ventricle from the aorta. The other problem with aortic valve is over a period of time, the aortic valve can get narrow. In some children, they are born with this narrow aortic valve. That is generally we talk about it as congenital aortic stenosis. But a large majority of patients who have aortic stenosis are adults. So they either have a abnormal aortic valve which degenerates and becomes narrow, or because of the aging process in some patients, in some elderly patients, the aortic valve degenerates, and because of that the aortic valve becomes narrow. So this narrowing of aortic valve is called as aortic stenosis. So when there is a narrowing, when the left ventricle pumps, the blood is not freely able to move into the rest of the body. This condition is called as aortic stenosis. So aortic stenosis, because the blood coming out of the ventricle into the rest of the body is impeded, there is some resistance to that, can give rise to a set of symptoms. Sometimes patients can experience chest pain, especially when they walk or walk fast or climb some kind of a physical or psychological exertion. When the heart beats harder, then they can have chest pain, what we call as angina. Commonly, patients have breathing difficulty. When they walk, they get breathless, and they sit down, they become relieved from the breathlessness. Extreme narrowing of the aortic valve reduces the blood flow to the brain, and people can have giddiness, or sometimes they can even fall down unconscious. So these 3 symptoms, chest pain, breathlessness, and the loss of consciousness or syncope, are said to be the 3 cardinal symptoms of aortic stenosis. These are common. There are a good number of patients with significant aortic stenosis who can be asymptomatic. They have no symptoms, but they are routinely, when they go for a routine heart check, then the doctor can find out that there is a problem in the heart, and then they are accidentally detected. But typically, if enough time elapses, almost all patients of severe aortic stenosis will eventually develop symptoms, and usually these are the 3 symptoms which we talk about. Unfortunately, aortic stenosis cannot be treated with medicines alone, and once a stage where severe aortic stenosis is reached, from little narrowing, the narrowing of the aortic valve becomes quite serious, patients will have symptoms, and once they have symptoms, there is a risk to their life. So therefore, aortic stenosis has to be treated in most instances, and replacing the aortic valve is the only known treatment for severe aortic stenosis. In the adults, at least we can talk about that. In younger children, there can be a balloon procedure which can help them, but in adults, replacement of the aortic valve is the only treatment for severe aortic stenosis. Now, replacement can be done in 2 ways. One of them is the traditionally done, what is called a surgical aortic valve replacement, or these days we call it as TAVR. And then where it's an open heart surgery, the chest is opened up and the valve, the heart is cut open, the valve which is diseased is removed, and an artificial valve is implanted and stitched into it. The other form of treatment, which is non-surgical, whereby valve which is compressed is taken up into the heart and it is released at the place where the diseased aortic valve. That is called as transcatheter aortic valve replacement or transcatheter aortic valve implantation. So these are commonly abbreviated as TAVR or TAVI. So this is a newer procedure available for the last decade and a half in the world, and this is the other kind of treatment. Either way, aortic stenosis, when it is severe and especially when it is symptomatic, the way to treat aortic stenosis is to replace the valve, and replacement can be done either surgically or by transcatheter, that is non-surgical method. What happens is a TAVR is an artificial valve. It is a bioprosthetic valve. The valve leaflets are made up of tissue, animal tissue typically, and then there is a kind of a metal mesh around that. It's called as some kind of a stent. So now inside that framework the valve leaflets are there and they are all crumpled, and that whole thing is mounted on a delivery system. So through incision in the groin, in the thigh artery, the delivery system is taken up through the arterial system across the aorta and inside the area where the valve exists. And once it is kept in the right position, the valve is deployed or opened up like an umbrella, and then the valve sits in that area and the delivery system is removed. Now this is unique when compared to a surgical aortic valve, not only because it avoids surgery on the chest and the heart, but also there are no stitches. The valve sits in the position by a mechanism of pressure, like how stents sit inside the coronary arteries. So similarly the valve sits. So TAVR is a reasonably simple procedure, at least to explain. That is, through an artery in the groin, the valve is taken up to the desired position and it is released there and it sticks there. And as soon as the valve is released, it starts functioning like a normal heart valve and the circulation is established. It's typically a short procedure.
Which age group are highly recommended for TAVR?
Now, as I told you that surgical aortic valve replacement is being the gold standard for aortic valve stenosis for a long time. It's a very age-old procedure, very durable, and we understand how surgical aortic valve replacement works and what are the long-term outcomes, how the patient's quality of life is, what is the life expectancy of a patient of a surgical valve. It all has been studied quite well. The transcatheter aortic valve replacement is a newer technology. So we still are learning a lot about the long-term durability of that. But where are these TAVR procedures unequivocally of benefit is, if a patient requires an aortic valve replacement but is too frail or has too many risk factors which make the patient unfit for a surgical aortic valve replacement, then definitely such patients will benefit. There are patients who are very old, patients who have had previous heart surgery like a bypass surgery or a previous valve replacement surgery. Some patients are there who have had lung disease, whereby the risk during anesthesia for an open heart surgery is very high. Such patients often are denied any surgery, saying that it's futile to operate on you because the risk to life of the patient during an open heart surgery is very high. So the surgeon says we cannot operate on such patients. They are the best candidates. As time progresses and as we have learned more about the TAVR procedure, we are now taking up more patients who are slightly higher risk for surgery, where surgery is also possible, where the patient doesn't want surgery. So these are the other group of patients. But unequivocal benefit is there in patients who are older, who have multiple other system diseases, what we call as comorbidities, because of which the risk of aortic valve open heart surgery is high. In such patients who are unfit or who are very high risk for open surgical replacement, those are the best candidates for TAVR procedure. So typically we admit a patient a day before the TAVR procedure, and then there is an anesthesia, and since there is no surgical opening and all that, it's done through the groin. the entire procedure should take somewhere between 1 to 1.5 hours. Typically, we observe these patients in the ICU or in a high def unit for a night, and after on day 2 or day 3, the patients can walk home if there are no complications. And usual recovery period is maybe 1 week, depending on how we do the procedure, whether it is on the groin, in the thigh, whether we cut open the artery or we do it through stitchless procedure, the recovery happens. So in general, we can say the patient can recover well within a week's time if there are no complications. I'll give examples of 2 patients who have benefited from this procedure. There was a patient who came to us last year who had a bypass surgery. He's 80 plus, elderly gentleman, reasonably active but a little frail, and he had a bypass surgery about 15-16 years ago, and he had developed a severe aortic stenosis. His aortic valve needed replacement. When we examined him and checked him, we also found out he has a critical block of one of the arteries. Typically, such a patient in the past would have undergone an open heart surgery and would have had a bypass surgery to the heart and a valve replacement surgery. We felt that this patient was high risk for this kind of a longish procedure, and the patient also was not willing for a high risk procedure. So we explained that we can simultaneously do an angioplasty for the artery and fix that using a stent, and then also do a TAVR procedure and fix the aortic stenosis. In fact, this patient underwent a complicated angioplasty procedure because his arteries were very calcified. We had to do what is called as a rotablator. It's a kind of a drill we use to remove the calcium and then implant a stent. Immediately following that, in the same sitting, he underwent an aortic valve replacement. In fact, this case where rota stenting and a TAVI procedure or TAVR procedure was done in the same sitting is perhaps the first in Karnataka. Now, this procedure was done sometime in July, and now after 1.5 years, this is July 2019, we did this procedure. He's doing very well. He's completely symptom free. Prior to this, he had difficulty in walking short distances. He would get angina, and now he's free from angina and he's leading a good quality life. An instance where TAVR procedure can be useful is also when there is a patient who has undergone a surgical aortic valve replacement and that valve has degenerated. Such patients have had the first surgery at an older age, because aortic stenosis is a disease of the older age, and then after several years you have a degeneration of the valve. The patient has become even older. I can recollect a patient who was 83 or 84, where about 12-13 years ago he had a surgical aortic valve replacement and the valve had degenerated over a period of time. Now he needed a replacement, but he was quite frail. Therefore, we decided that instead of subjecting him to a second open heart surgery, we can do a TAVR procedure. So what we did was we implanted another valve, a TAVR valve, through the groin without subjecting him to an open heart surgery inside the old valve which had degenerated. So this kind of procedure is called as a valve-in-valve procedure. In fact, if I recollect correctly, the valve-in-valve TAVR was the first to have been done in Karnataka state. Of course, it has happened across the world in quite a large number, but this was the first time it was done in Karnataka, and we performed that. And after about 1 year, more than a year's follow-up, this patient is doing very well, and his quality of life has improved because of that. So this is the kind of patient where patient has had previous surgery, whether it is a bypass surgery or previous aortic valve surgery, where the patient requires a second surgery and is elderly and frail. That would be an ideal situation where TAVR can be considered.